Hey everyone, today I'm going to talk about megaloblastic anemia in children. The content of my presentation is going to be introduction, folate deficiency, and vitamin B12 deficiency anemia. Megaloblastic anemia describes a group of disorders that are caused by impaired DNA synthesis. Red blood cells are larger than normal at every developmental age if there is impaired DNA synthesis, and also there is maturational asynchrony between the nucleus and the cytoplasm of the erythrocytes. The delayed nuclear development becomes increasingly evident as cell division proceeds. And also myeloid and the platelet precursors are also affected. And giant metamyelocytes and neutrophil bands are also present in the bone marrow. There is also associated thrombocytopenia and leukopenia in children with uh, megaloblastic anemia. The peripheral blood smear is notable for large, often oval RBC with increased immune corpuscular volume, and also neutrophils are characterized by hypersegmentation with many of them having greater than 5 lobes. Most cases of childhood megaloblastic anemia results from deficiency of folic acid and also vitamin B12. Those two vitamins are essential for DNA synthesis. In addition to those two common causes of megaloblastic anemia, rarely anemia caused by inborn errors of metabolism can also cause megaloblastic anemia. When I, let us go to see about the two most common causes of megaloblastic anemia in children. They are folic acid deficiency and vitamin B12 deficiency. From this, let's start about folic acid deficiency. Uh, Folic acid consists of conjugated biologically active folates are derived from folic acid and they serve as one carbon donors and also acceptors in many biosynthetic pathways. To form functional compounds, folate must be reduced to tetrahydrofolates in a process catalyzed by the enzyme dihydrofolate reductase. As such, they are essential for DNA replication and also cellular proliferation. Like other mammals, human cannot synthesize folate and also it depends on dietary sources including green vegetables, fruits, and animal organs like liver uh, to gain folates. And also folates are heat labile and water soluble. Consequently, boiling or heating folate source leads to decreased vitamin, decreased folate levels in that foods. Naturally occurring folates are in polyglutamate form that is less efficiently absorbed than the monoglutamate species. Dietary folate polyglutamates are hydrolyzed to simple folates that are absorbed primarily by the proximal small intestine by a specific carrier mediated system. Folate travels in the bloodstream and they are taken up in cells primarily in the form of unconjugated methyl tetrahydrofolate, which is subsequently reconjugated in the cell. There is active enteropathic circulation of folates. Although rare, megaloblastic anemia as a consequence of folate deficiency has its peak incidency at 4 to 7 months of age. This is somewhat earlier than that of iron deficiency anemia. That of iron deficiency anemia is nutritional iron deficiency anemia is around 9 months to 2 years of age. But sometimes both iron deficiency and also folate deficiency anemia can coexist. Body stores of folate are so limited and the deficiency can develop quickly in malnourished individuals. If a child eats a folate-free diet, megaloblastic anemia will occur as short as in 2 to 3 months of period. When we came to etiology of folate deficiency in children, there are multiple causes of folate deficiency in children. From this, inadequate nutrition, defect in absorption, increased requirement, and the likes are so common. But from this, uh, the most common cause of folate deficiency is inadequate folate intake. Folate requirements are higher during the periods of increased vitamin requirements, such as during pregnancy, during periods of accelerated growth, and also during periods of chronic hemolysis. Folate requirements is greatly increased during pregnancy. This is in order to meet fetal needs, and also deficiency are common in mothers, particularly those who are poor or malnourished. Folate supplementation is recommended from the start of pregnancy to prevent neural tube defects and also to meet the needs of developing fetus. Fortunately, folate deficient mothers generally do not give birth to infants with clinically folate deficient because there is selective transfer of folate to the fetus via placental folate receptors. Rapid growth after birth increases demands for folic acid, and infants who are premature or ill and those with certain hemolytic disorders will have particularly high folate requirements. Human breast milk, infant formula, they have adequate amount of folic acid, but goat milk is folate deficient, and if a child is if goat milk is a child's main food, supplementation must be given. So goat milk, if it is not supplemented, it is associated with folate deficiency. Malnutrition is the most common cause of folate deficiency in older children, and those with hemoglobinopathies, infections, or malabsorptions are at increased risk. As we have said, because body stores of folates are limited, deficiency can quickly develop within 2 to 3 months if a child took folate-free diet for 2 to 3 months. The other causes are decreased folate absorption. Malabsorption caused by chronic diarrheal states or diffuse inflammatory disease can lead to folate deficiency. In both situations, in both chronic diarrheal state and also in diffuse inflammatory disease, some of the decreased folate absorption may be caused by impaired folate conjugase activity. Chronic diarrhea also interferes with the enterohepatic circulation of folate, thereby enhancing folate losses because of rapid intestinal passage. Megaloblastic anemia caused by folic acid deficiency can occur in celiac disease, chronic infectious enteritis, and also in patients who have enteroenteric fistulas. Previous intestinal surgeries is also another potential cause of decreased folate absorption. Certain anticonvulsant drugs such as phenytoin and rivaroxaban can impair folic acid absorption, and many patients treated with these drugs have low serum folate level. Frank megaloblastic anemia is rare, and rarely it responds to folic acid therapy, even while we continue the drug. In adults, alcohol overuse is also associated with folate malabsorption. Increased requirements are during the periods of pregnancy and lactation, as we have said, premature children, chronic hemolytic anemia, in patients who are on dialysis, in a child who have hyperthyroidism, the like. Disorder of transport such as cerebral folate deficiency and also disorder of cellular metabolism, as we have said, drugs and also inherited defects of, for example, in the reductase deficiencies, methionine synthesis deficiencies, dihydrofolate reductase deficiencies can cause folate deficiency anemia, which is megaloblastic anemia. When we came to clinical manifestation, the the clinical manifestations of anemia due to folic acid deficiencies, most of them are general. It's non-specific. Such as shortness of breath, tachycardia, lack of energy, or easy fatigability, dizziness, vertigo, and also headache and irritability they are non-specific signs of anemia. Symptoms more common in folate deficiency anemia are such as irritability, chronic diarrhea, poor weight gain, and also since they are at risk of having thrombocytopenia, hemorrhages may also occur in advanced cases. When we came to laboratory finding, first of all, from CBC, we have low hemoglobin or hematocrit count, and also RBC counts are low. In addition, variation in RBC shape and also size are common, which manifests by high red cell distribution width and also high MCV count. That makes it macrocytic anemia. Occasionally also neutropenia and thrombocytopenias are common if the severe of anemia is high. The reticulocyte count is also low, and the nucleated RBC with megaloblastic morphologies are seen in peripheral morphology. The neutrophils are large, some with hypersegmented nuclei, and the bone marrow, if bone marrow analysis is done, if bone marrow biopsy and also aspiration is done, hypercellularity of bone marrow can be seen because of erythroid hyperplasia and also megaloblastic changes can be seen. Large abnormal neutrophilic forms or giant metamyelocytes with cytoplasmic vacuolations are also seen. We can also do serum folic acid levels to check folate deficiency. If serum folic acids are less than 3 nanogram per ml, it is called folate deficiency. But rather than serum folic acid levels of RBC folates are a better indicator of chronic deficiency because serum folic acids are easily corrected. Even if a child is admitted for 1 or 2 days to hospital and eating some adequate amount of food that have adequate folic acid, the serum folic acid can be corrected, but the RBC folates are deficient. So it's better to do RBC folate than serum folate level to confirm the diagnosis of folate deficiency. The normal RBC folate levels is it's around 150 to 600 nanogram per ml of RBC. In addition, serum activity of lactate dehydrogenase can be increased. This is a marker of ineffective erythropoiesis. Sometimes also levels of iron and the vitamin B12 in serum can be usually normal or elevated in patients with folate deficiency. When we come to treatment, when the diagnosis of folate deficiency is established, folic acid may be administered orally or parenterally at a dose of 0.5 to 1 milligram per day. If the specific diagnosis is in doubt, that means if we suspected vitamin B12 deficiency and also folate deficiency, if we didn't separate them, which causes anemia, smaller dose of folate around 0.1 milligram per day may be used for 1 week as a diagnostic test because hematologic response can be expected within 72 hours. Dose of folate greater than 0.1 milligram can correct the anemia of vitamin B12 deficiency, but it might aggravate any associated neurologic abnormality if the cause of anemia is vitamin B12 deficiency. So, treating megaloblastic anemia due to vitamin B12 deficiency with folate can correct the anemia, but it might worsen the neurologic manifestations of vitamin B12. So it is important to differentiate folate deficiency from vitamin B12 deficiency before treatment. Folic acid therapy, that means 0.5 to 1 milligram per day, should be continued for 3 to 4 weeks until a definitive hematologic response has occurred. And the maintenance therapy can be continued with multivitamin, which contains around 0.2 milligram of folate daily after correction of the hematologic anemia. Very high dose of folate may be required in the setting of congenital causes, and also transfusions are indicated only when the anemia is severe or the child is very ill. So transfusions are indicated if the child is in cardiac failure or at imminent of heart failure, or when the anemia is very severe. Otherwise, we can treat folate deficiency anemia with folic acid 0.5 to 1 milligram daily for 3 to 4 weeks. The other cause of megaloblastic anemia is vitamin B12 deficiency or cobalamin deficiency. Vitamin B12 is a generic term encompassing all biologically active cobalamins. It is a water-soluble vitamin with central functional cobalt atom and also planar chlorine ring. Methylcobalamin and adenosine are the metabolically active derivatives, and they serve as cofactors in two essential metabolic reactions. Those two essential metabolic reactions are methylation of homocysteine to methionine and also conversion of methylmalonyl coenzyme A to succinyl-CoA. Those products and the byproducts of these enzymatic reactions are critical in DNA, RNA, and also protein synthesis. Cobalamin is synthesized exclusively by microorganisms, and humans must rely on dietary source. Animal products including meat, eggs, fish, and also milk have adequate amount of cobalamin. So we depend on those things to gain cobalamin to our body. Unlike folate, unlike folate, older children and adults have sufficient vitamin B12 stores for at least 3 to 5 years. So uh, children have at least 3 to 5 years of vitamin B12 stores. In young infants who are born to mothers with low vitamin B12 stores, clinical signs of cobalamin deficiency can become apparent in the first 6 to 18 months of life. So, if a mother is deficient with folate, the clinical manifestation will appear within 3 to 4 months. Whereas if the mother is deficient with vitamin B12 stores, uh, the baby will develop signs of anemia at around 6 to 18 months of life. If a child eat a folate-free diet for 3 to 5 months or 5 to 7 months, they will develop folate deficiency anemia. But if they eat a vitamin B12 deficient diet for more periods, they will not develop the anemia. So it requires around 3 to 5 years because the body stores of vitamin B12 are prolonged. It is high. When we came to etiologies of vitamin B12 deficiency, there are many causes of vitamin B12 deficiency. From this, inadequate dietary intake of cobalamin, lack of intrinsic factor, impaired intestinal absorption of uh, intrinsic factor with cobalamin, and also absence of vitamin B12 transport proteins are the cause. When we came to inadequate vitamin B12 intake, vitamin B12 deficient infants is most often nutritional. It results from low cobalamin levels in breast milk or in low cobalamin levels in the breast milk of B12 deficient mothers. Associated megaloblastic anemia it often appears in the first year of life. If the mother is deficient in vitamin B12, so there is low amount of vitamin B12 in the breast milk, the child will develop megaloblastic anemia from B12 deficiency during the first year of life. Maternal deficiency may be caused by also pernicious anemia and also by gastrointestinal disorders such as H. pylori infection, celiac disease, chronic disease, and also pancreatic Crohn's disease, and also pancreatic insufficiency. Previous gastric bypass surgery and also treatment with proton pump inhibitors and also inadequate intake from strict and supplemented vegetarian diets can cause uh, deficient vitamin B12 stored in the mother, and this predisposes the child for vitamin B12 deficiency in the first year of life. But fortunately, as a result of active placental cobalamin transport in utero, most children of B12 deficient mothers maintain cobalamin levels sufficient to support adequate prenatal development. Such infants are born with low B12 stores, the depletion of which is associated with gradual onset of clinical manifestation. Vitamin B12 replacement often results in rapid improvement, but the longer the deficit period, the greater the likelihood of permanent disability. The daily requirements of vitamin B12 is around 0.4 to 2.4 microgram. Impaired vitamin 12 absorption is caused by either gastric surgery or medications that impair gastric acid secretion, such as proton pump inhibitors, H2 receptor blockers, and also it may result from intrinsic factor deficiency. It might result from pancreatic insufficiency, which causes uh, which lead to cobalamin deficiency because of impaired cleavage and the intrinsic factor complex formation, and also neonatal necrotizing enterocolitis, inflammatory bowel disease, celiac disease, and surgical removal of terminal ileum, which is the site of B12 absorption, may also have impaired absorption of vitamin B12 deficiency. And also an overgrowth of intestinal bacteria within the diverticula or duplication of the small intestine can cause vitamin B12 deficiency. Hematologic response can follow appropriate treatment. Endemic areas, for example, fish tapeworm can also cause vitamin B12 deficiency. And also sometimes absence of vitamin B12 transport protein, which is called Cobalamin deficiency, can predispose for vitamin B12 deficiency. When we came to clinical manifestations of vitamin B12 deficiency, there is non-specific manifestation. Any signs of anemia can happen, such as weakness, lethargy, feeding difficulty, failure to thrive, and also irritability. And also other common findings include, which are more specific to B12 deficiency, pallor, rather than pallor. Pallor can happen due to any cause of anemia, but glossitis, vomiting, diarrhea, and also icterus. Neurologic symptoms can include paresthesia, sensory deficits, hypotonia, seizures, developmental delay, and the developmental regression, and also neuropsychiatric changes, which might have some CT scan or MRI finding might happen. Neurologic problems from vitamin B12 deficiency may occur in the absence of any hematologic abnormalities. When we came to laboratory finding to differentiate it from other cause of megaloblastic anemia, the hematologic manifestations of folate and the cobalamin deficiency are almost identical. MCV is high with prominent macrophagocytosis of the RBC. Neutrophils are large and hypersegmented, most of the time greater than 5 lobes. Neutropenia and thrombocytopenia can occur in severe forms of B12 deficiency, which might confuse with aplastic anemia and also leukemia. To differentiate folate deficiency from vitamin B12 deficiency, the other important thing is serum vitamin B12 and the serum folate level. So in vitamin B12 deficiency, there is low vitamin B12 levels in the serum. And also, in addition, we can investigate the metabolite level. Serum concentration of metal-malonic acid and homocysteines are usually elevated in vitamin B12 deficiency, whereas in folate deficiency, only homocysteine levels are elevated. And also, serum lactate dehydrogenase activity is markedly increased, which is a reflection of ineffective erythropoiesis like that of folate deficiency. So to differentiate folate from B12, one, there is neurologic symptoms in B12 deficiency. Second, serum levels of both vitamin B12 and also folate should be determined. Third, intermediate metabolites such as methyl malonic acid and homocysteines are elevated in B12, whereas only homocysteines are elevated in folate deficiency. When we came to the treatment of anemia caused by vitamin B12 deficiency, first we should have to search for the cause of vitamin B12 deficiency, and the dose and duration of treatment is based on the etiologic agent for B12 deficiency. We can treat a child with megaloblastic anemia from vitamin B12 deficiency with cyanocobalamin, IM, or sometimes subcutaneous for first 5 to 7 days, 1000 microgram per day IM, followed by 100 microgram per week, once weekly for a month. Then, if the cause of vitamin B12 deficiency is corrected, it is enough. Otherwise, if there is chronic malabsorptive state or if it is pernicious anemia, it needs monthly 100 microgram for long time. The physiologic requirement for vitamin B12 is about 1 to 3 microgram per. Thank you. This is all about megaloblastic anemia due to folic acid and also B12 deficiency. Please subscribe, like, share, and comment for further pediatric lessons, pediatric lectures. Thank you.